I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Clinical strategies and choice.
I did try, but it fell once. Gotta go for some more.
Although my identification is primarily as a researcher of ECT, today I've been asked to dwell on some clinical considerations. And this is somewhat of a relief as it excuses me from providing a long list of references and even from showing any slides. The title, Clinical Strategies and the Choice and Timing of ECT, necessarily requires me to consider a variety of points that have been left out, sort of a tail-end, ragbag collection of different kinds of considerations that clinicians are concerned with when managing their patients for whom they wish to give ECT. And to start with considerations of choice, we have already heard the double-blind controlled studies of ECT, affective disorder, and schizophrenia. And these, of course, provide the basic data, the basic strategy for defining the efficacy of treatment and leading to the proper choice of treatment. However, within the diagnostic groups already discussed, there remains some consideration of what I feel are important clinical nature. For example, traditionally, and this is based not only on clinical tradition, but on a substantial series of research papers, starting with Hobson in the 1950s, continuing with the Carney group in England, Newcastle in the 1960s, and Mendel in the United States. There has been a traditional dichotomy of depression into endogenous and reactive, or melancholic and non-melancholic. And actually, some of the best data in the literature demonstrate that those patients with the subtype of endogenous depression, or melancholia, as it's now more suitably termed, have the best response to ECT. And that those patients within the old terminology would be called reactive depressors or neurotic depressors, or who might now be termed possibly dysthymic disorder, although that is not really coterminous with neurotic or reactive depression, have the worst response to ECT and probably should not receive this treatment. Within the overall category of melancholia, and I'm referring now to data which has been presented in controlled trials, certain clinical features have augured well for a response to ECT. For example, the phenomenon of early morning waking and the related symptoms, diurnal mood swings in melancholia, the presence of psychomotor retardation and its more severe form, stupor, the presence of agitation, the presence of significant weight loss that is in excess of 5 pounds, the presence of anhedonia, pervasive loss of pleasure and interest in all aspects of life, the presence of ruminations. The form is rumination. The content may take various aspects, such as ruminations of guilt and self-reproach, ruminations of hopelessness, leading to suicidal ruminations, worthlessness, and ill health. All have been shown to predict a good response, a favorable response to ECT. These ruminating features may progress to psychotic proportions and be expressed in the form of delusions or hallucinations. Interesting, and different from many other aspects of medical practice, those patients with the severest form of the depressive illness, that is, with the psychotic features and the delusions and the hallucinations of guilt, hopelessness, etc., very often do the best with treatment. It's almost unique in medical practice, but there is data to support it. Historically, there are features which predict a good response to ECT. Of course, one of them is a prior good response to ECT. A second is a family history of depression or of mania. And the third is a personal history in the patient of mania, hypomania, or cyclothymia. And then finally, there is one well-known personality feature, if you will, that the response to ECT is often superior in individuals who have a stable or well-adjusted premorbid personality. Now, in contrast to this melancholic syndrome is the syndrome and the features of reactive or neurotic depression, which, as I say, has not really been included in a recognizable form in DSM-3, but which clinicians who are giving ECT very well recognize or ought to recognize, because these are features which predict a poor response to ECT. Some of these features are excessive self-pity, a tendency to blame others for their troubles, as opposed to the self-blame which occurs in melancholia. High degrees of anxiety, both subjective and objectively manifested. The phenomenon of initial insomnia. And then a marked reactivity of the mood to environmental circumstances. Tearfulness. And in cases which have been described in the literature as so-called atypical depression, the triad of hypersomnia, increased appetite, and occasionally increased libido. These are poor prognostic features for ECT response. I think it's important to note in this context that whether a depressive episode is precipitated or not is irrelevant. There is a very nice paper from the 60s from the British literature which shows that the melancholic and the non-melancholic syndromes are equally likely to have been precipitated by an external environmental event. Incidentally, as has been noted previously, many features of this melancholic syndrome have been related to altered diencephalonic, specifically hypothalamic functioning, and this matter has been reviewed in detail in a very nice monograph from the 60s by John Pollock, also from England. Within the context of the differentiation between endogenous and reactive melancholic and non-melancholic syndromes, there are two laboratory procedures which have been recommended. One is the sedation threshold test, now largely abandoned simply because of the possible some technical problems with it, but both the studies of Chagas and later on of Perez-Reyes have shown that the administration of intravenous barbiturate, either pentobarbital or sodium amylbarbital, at a standardized milligram per kilogram per minute rate, and using either EEG criteria as an endpoint or inhibition of the galvanic skin response as an endpoint, very nicely differentiates the melancholic and non-melancholic syndromes with normals falling in between, and that this is highly predictive of the response to ECT. Patients with a low sedation threshold, that is those who readily fall asleep or whose central nervous system is rapidly inhibited by barbiturate narcosis, have the best response to ECT, and those who are resistant to the effect of barbiturate, central barbiturate narcosis, have a poor response to ECT. This has been related to increased central excitability as manifested by galvanic skin response, for example. Another test, the dexamethasone suppression test, although by possibly not living up to its original widely heralded uses, has been reported to differentiate melancholic from non-melancholic depressants and has been used both to predict the response to ECT and to follow the response of ECT patients during their course. Contradictory data exists on this, without evenly divided, but certainly some evidence has been introduced in favor of this as a measure of treatment response and perhaps as a predictor of relapse. Moving on, yeah, could you close the door in the back, please?
Please close the door in the back.
Thank you. Moving on to another syndrome which has not been discussed or touched upon only briefly, what has been termed the pseudo-dementia syndrome of depression, originally described by Simon and Roth in one of the earlier, and detailed fully in one of the earlier editions of the textbook of Slater. This is a syndrome in which a person, generally over the age of 60 or 65, presents with what appears to be a syndrome of dementia, cognitive dysfunction. It may be very severe. There may be every evidence for a profound dementia, but in the presence of symptoms of depression, that is weight loss, apathy, retardation, hopelessness, suicidal hallucinations, etc., and despite the marked physical debilitation which is often found in these patients, the response to ECT may be dramatic. To my knowledge, there is no reported study, no controlled trial, and really very little in the way of accumulated cases under a single author. However, anyone who has been in the practice of ECT would probably agree that some of the most dramatic responses to ECT occur in some of these elderly, debilitated, depressive, whose primary affective disorder masquerades as a senile dementia. And possibly since the introduction of Medicare reimbursement for ECT, the experience of this group of patients has accumulated to a much greater extent than before. Another condition which should be mentioned is delirious mania. Again, not a category you'll find in DSM-3. Actually, to paraphrase Shakespeare, I should say that there are more things in heaven and earth Horatio than I've dreamt of in DSM-3. The notion of delirious mania, otherwise termed Bell's mania, regal catatonia, Stauder's disease, febrile catatonia. Clinicians recognize this entity as being acute manic excitement state with clouding of sensorium, sometimes associated with fever, often with dehydration, tachycardia, and severe or total insomnia. This has also been called, under some rubrics, periodic catatonia or catatonic excitement states. All are basically describing the same syndrome. It has an untreated mortality rate, which has been reported. I'm not aware of any systematic trials in such patients. They are not that frequent. However, the clinical wisdom is, and experience by practitioners, is that ECT may be the only effective treatment in these patients, and that in those who have a large experience, it is considered to be life-saving. Neuroleptics are generally not effective or may aggravate the syndrome generally due to their anticholinergic effects. The fever, the dehydration, and the clouding of sensorium are key features of this manic excitement state. Catatonic stupor is another indication for ECT, which has not really been considered. It's hard to accumulate a sample of people in negativistic stupor manifesting the phenomena of stupor, mutism, and negativism. Nonetheless, traditionally, it is one of the most rapidly responsive of all syndromes to ECT. It itself is a nonspecific syndrome, frequently found in affective disorders, but also in schizophrenia, of course, brain disease, and occasionally even in hysterical or reactive states. A sodium amytal interview of such a patient will help both in making the diagnosis and in predicting the treatment response, because those patients who have a rapid response to intravenous sodium amytal, even if only temporary, usually do very well with ECT. This brings us to another group of disorders which have been referred to again, the acute schizophreniform, schizoaffective, or good prognosis schizophrenic disorders, also termed in the Japanese literature atypical endogenous psychosis, and in the Scandinavian literature as psychogenic or reactive psychosis. These are a group of disorders that have been classed either as schizophrenic or schizophrenic-like. Von Meduna, appropriate to mention here, called them oneirophrenia, that is dreamlike schizophrenia. They're characterized by the usual good prognostic signs which in past years were made much of with regard to ECT response. And these good prognostic signs are sudden onset, the presence of a precipitating event, a clouded sensorium, good premorbid functioning, and the presence of a broad affect. And within the context of these good prognostic signs, these acute states manifest themselves by excitement and by proliferative psychopathology, delusions, hallucinations, and so forth. Our studies, my studies with Taylor and those of many other people, find these conditions generally to be indistinguishable from affective disorder on any criteria chosen, whether treatment response, family history, or past history. And ECT may be the most efficient treatment for these patients. Drug treatments are often tried first, and we'll come to later the question of strategies and the timing of ECT, but ECT may be dramatically effective in such patients. Finally, there are a variety of indications for ECT which are drawn from the exogenous psychoses. And that is, ECT may exert a non-specific effect in patients who suffer from a variety of psychotic states secondary to hallucinogens, especially PCP and LSD, to exogenous toxins such as bromine psychosis, to the psychoses of endocrinopathies, myxedema madness is a good example, vitamin deficiency, pernicious anemia, infectious etiologies, encephalitis, head trauma, closed head injuries, temporal lobe epilepsy, and withdrawal syndromes from opiates, alcohol, and barbiturates. These, again, have not systematically been studied, but have been reported in numerous case reports and accumulated studies by Roberts and Greenspoon and Martin Roth have described this. Going on to the question of timing of ECT, one question is always, when should ECT be the initial treatment of choice, or should ECT ever be the initial treatment of choice? Certainly, no controlled trials of this have been done. We have proposed some large collaborative studies which were never funded. Maybe they will be done someday. Until that point, general recommendations are, as an initial treatment of choice, ECT over drugs in patients with a melancholic syndrome who have, in addition, psychosis, that is delusional depression, present a serious suicidal risk, who are severely agitated or stuporous. In other patients, ECT as the initial treatment of choice has been recommended in catatonic stupor, delirious mania, and in psychosis occurring during pregnancy, where questions of the safety to the fetus for the adverse effects of neuroleptics, lithium, and tricyclic antidepressants are deemed to be greater than the effects of ECT, which is not known to have any adverse effects on the fetus. Another instance where ECT could be used as the primary indication would be patients with serious medical disorders, which made drug therapy risky, depressives with heart block, psychotic patients with narrow-angle glaucoma or prostatic hypertrophy who would not do well with the anticholinergic effects of drugs. ECT, the choice of ECT in drug non-response is also a question. Again, no data exists on this. My recommendation is that in melancholics who show absolutely no response to 1 week of tricyclics, ECT is indicated. The statistics show, both studies, that the majority of the response to tricycle is the drop in Hamilton scale occurs in the first week of treatment. Acute psychotic excitement stage with no response to 5 to 7 days of parenteral neuroleptics should receive ECT. And subacute psychotic stage, usually manic, with no response at all for 2 weeks of lithium at therapeutic levels would be my recommendation. Emergency ECT, the question of timing has been mentioned, certainly for serious suicide or a self-mutilated attempt, or sudden sharp, life-threatening deterioration in a previously stable or patient. Other questions of frequency of administration of treatments, whether 3 times a week or twice a week, questions of multiple treatments and total numbers of treatments play a less important role. I would like to just mention that in this country we give treatments 3 times a week. In the United Kingdom they're given twice a week. They don't appear to be any less effective in the United Kingdom. And even with bilateral ECT, one frequently observes that their patients complain of memory loss and confusion than ours do. And at this point, I think I'll just stop.
Thank you.
One shock treatment can equal 150 joules of energy. This is equal to dropping a hammer on someone's head from higher than a 5-story building.
At the FDA hearings, the testimony on the reclassification of electroconvulsive devices cited the literature as whether signed or false, typically about 150 joules of energy in a treatment. With the new Thymatron electroconvulsive device, if you check out at 400 volts maximum of 0.9 amps and 320-some millisecond pulses.
Could you finish up your question, your remarks?
Yeah, I would like somebody to tell me. I'm a teacher as well as a physicist, and I brought a kilogram with me. Teachers like to demonstrate. Now, this is a kilogram. It's 2.2 pounds. Heavier than a hammer I used to hit an amp. That I wonder if possibly like Dr. Stein could tell me how high I would have to drop this kilogram from in order to have it hit the ground with 150 joules of energy.
I don't know if that question is in the purview of the panel, but thank you for your report.
Well, just a minute.
I'd like to go on to the next person.
This is only 10 joules of energy. You're talking about dropping it from higher than a 5-story building. That's physics. Supposedly in pre-med backgrounds.
Thank you.
I never got it.
All right, out with your gun. Huh? Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
Uh-huh. What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson?
Open your mouth.
What's that?
This will keep you from biting your tongue.
Well?
Now just bite down on it.
Oh.
That's right. Just bite down.
Huh?
Now bite down on it.
Good. Are you ready?
Ready.